So, I am here to discuss a new session on National Tuberculosis Control Program. In this program, we will discuss about the goals and objective of National Tuberculosis Control Program. Then we will further discuss about the treatment strategies. Okay, so let us start. Some key notable points in this. So, diagnosis in revised National Tuberculosis Program. We will discuss the what is revised National Tuberculosis Program. So, the diagnostic test means which is used for the confirmation of this TB, we are using Zeal-Nielsen staining. Yes, we have recognized World TB Day on 24th March. Okay, TB was declared as global emergency in 1983. Yes, by the World Health Organization. So, these are some key points which you should note or keep it in your mind. Yes, TB is the most common opportunistic infection. Yes, means whenever the immunity is low. So, this is the most common infection the patient is getting. Yes, most common opportunistic infection, especially with HIV, because HIV in the HIV immunity is low. Yes, then elimination level for TB by the WHO and the Stop TB strategy, we have taken the target as less than 1 case per million. If it is, the condition is met, we will say yes, the disease is eliminated. Yes. After that, we will discuss on the National Tuberculosis Program or revised National Tuberculosis Program. So, what is the difference? First program on the tuberculosis for the prevention or the control was launched in 1962, which is known as NTP, National Tuberculosis Program. What was the objective, operational target, strategy and diagnosis? There are some differences, we will see. So, after the 1962, after so many years, there was one program in 1992. Okay, which is known as revised National Tuberculosis Program. So, we have done the revision here. Okay. This revision, because we did the revision, there are some you can say differences. So, objective for the NTP was early diagnosis and treatment. Okay. But in 1992 we changed the objective. Our objective is to breaking the chain of transmission. Yes, this is the first difference. Then what are the operational targets? So, it was not defined in NTP, National Tuberculosis Program, but after the revision we have given 2 targets. So, cure rate should be more than 90%, of course, by implementing the therapy. Yes, and case finding should be more than 90%. Okay, active approach or passive approach, both. Then strategy. So, what we did, we done the SSC supervised. Okay. So, will these members, means ASHA workers or all these members, they will supervise. Okay. Then the strategy used here is the conventional. In the RNTCP, DOTS therapy we have used, okay, directly observed therapy we have used, and uninterrupted drug supply. Okay. So, that we can maintain the compliance. After that, diagnosis. So, more emphasis we have given on the X-rays in the NTP, whereas sputum analysis we did in the RNTCP. So, this is the basic difference here. Now, see the objectives of the revised National Tuberculosis Program. So, this is a recent one, we will discuss these objectives. Okay. See, to achieve a cure rate of at least 85%, okay, through administration of SCC, yes, short course therapy, and to achieve a case detection rate of 70% only after having achieved the desired cure rate. These are some objectives. Then what is the history? So, history was for implementing the this revised National Tuberculosis Program. This revised National Tuberculosis Program was based on the directly observed this therapy, directly observed treatment therapy, which was begin as a pilot, means on the short level, on a very small group in 1993. Okay. Then it was implemented on a bigger level in 1997. Yes. Rapid RNTCP expansion started in the 1998, and in 2006 the entire country was covered with this directly observed treatment. Yes, directly observed therapy for the tuberculosis. Now, what is the directly observed therapy? See, directly observed treatment short course. It is the community based tuberculosis. In this, by the name, it is very clear that here who will supervise the healthcare workers will supervise the therapy. Okay. So, the community healthcare workers are involved with supervising the therapy. So, there could be the social health worker, yes, ASHA workers, yes, pharmacists, nurses, they are also involved in this, yes, doctors. So, what are the success of the DOTS? How will achieve the success in the directly observed therapy? So, we need some commitment, yes. So, political commitment, okay, political funding, yes, good quality sputum microscopy, yes, because they are diagnostic test, directly observed treatment, okay. So, they will supervise the treatment, they will supervise the patient. Uninterrupted supply of good quality drugs in those areas where the patients are not able to access the facility, okay. And accountability is important. We have noted 2 patients, where are these 2 patients, they have taken the full treatment or not, yes. So, this is known as accountability. We need all of these points or components to make success for the DOTS, yes. Now, high cure rates, ensure high cure rates through 3 components. How will improve our cure rate? So, we will implement the medical treatment, we will supervise and motivate our health workers, okay. Health workers, if they are motivated, of course, they will motivate the patients. So, supervision and motivation by the health or non-health personnel, monitoring of the diseases, okay, by health services. What are the health services? Like sputum test, then X-ray, okay. So, these are some tests we will use. Now, DOTS is given by peripheral health staff. Who are the peripheral health staff? Like multi-purpose workers, voluntary workers, okay, like teachers are involved in this, Anganwadi workers are, DAIs are involved, and on successful completion of the treatment, we are providing some incentive to the these DOTS agent. So, it is here 150 per patient for completing the treatment, okay. This is under our revised national tuberculosis control program. After that, the drugs which are given to the patients. So, there is a therapy, means therapy timings. So, the duration of the therapy, normally if it is 6 months, I am just taking an example here, if the therapy time duration is 6 months. So, there are 2 phases in it, okay. One is known as intensive phase and another is known as continuation phase, okay. In intensive phase, what we are doing means we are giving the therapy to the patient only for the 2 months, okay. In the continuation phase, the therapy is for 4 months. There are some changes in the drugs as well. So, we will see what are the changes. So, what I told you is the intensive phase and the continuation phase. See what is written in intensive phase, each blister pack has a 1-day medication. So, supervision will be done and we will see what the patient had taken on a single day basis, okay, daily basis we will check. On the continuation phase, what we will do? We will check the blisters, will dispense the blisters for 1 week, okay, and after the 1 week we will go for the, means the patient will go for the follow up, or we will see, yes, the what the patient had taken for the 1 week, yes. Now, principles of the DOTS administration. So, the principle are involvement of health worker first of all. Second, during continuation phase the patient is issued medication for 1 week as I told you in multi-blister combi pack, for which the first dose is swallowed by the patient in presence of the health worker, in presence of teacher or Anganwadi workers, whosoever is working in this. Okay. Consumption of medicine in the continuation phase is also checked by the return of empty multi-blister combi pack. How will check? Yes, the patient had taken, so we will check the multi-blister combi pack, they are empty or not. Okay. On that basis we will dispense the 1 week the medication for the 1 week. Okay. In this program alternative treatment is used. Patient compliance is critically important throughout the prescribed period of the treatment. Why we are doing this? Because the TB treatment is taking a long time. Yes, just because of the long time patient are not following the compliance. So, we need someone should directly observe the patient, directly observe the therapy, so that we can improve the compliance. Okay. The patient should not reach on the stage of the resistance. So, this we are improving here, okay, by implementing the DOTS therapy. Now, other principles under the DOTS administration, drugs are given category wise. Okay. Same regimen is not used for all patients because the criteria for the patients are different. So, there are some categories like category 1. Okay. Category 1 patients are the normal or a new patient. Patient gone for the test and infection, we have reached on the infection. So, we will prescribe the treatment to the patient, that is the category 1, means new patients. Okay. Then there is a category 2 patient. Category 2 patient means the patient who are defaulters. Patient had taken the therapy for the 2 months and then patient start to skip the medication. So, that are the defaulter cases. Okay. Then under the category 2 there are some failure cases. Okay, means the therapy which we have given, it is failed, it is not effective on the patient. There are so many reasons, means the resistance has developed. So, under the category we can see the defaulters or failure of the therapy. Okay. After that there are category 3rd patient. Okay. Category 3rd means there is a MDR TB, multi-drug resistant TB. So, therapy is different for the multi-drug resistant TB. There is also category 4. Okay. So, we will see there is a one table which is showing these type of categories. So, category 4 is showing the XDR, okay, extensively multi-drug resistant TB. Now, see infrastructure. The RNTCP designated under this revised national tuberculosis program, we have set it the microscopy center. Okay. These microscopic center we have established on 1 lakh population. Okay. Now, 50,000 in hilly and mountainous area. So, for the normal for normal areas for 1 lakh population, but for the hilly and mountainous area it should be for 50,000 population. There is a one lab senior TB laboratory there is a one person senior TB laboratory supervisor who is supervising at least one STLS senior TB laboratory supervisor is supervising 5 labs. Okay, 5. These are the 5 labs, 5 microscopy labs. Okay, 5 microscopy centers. So, 1 STLS per 1 lakh population, because one microscopy center is 1 lakh population. So, ultimately 1 STLS senior TB laboratory supervisor will assess 5 lakh population. Okay, what they will do, they will randomly select or they will check the positive slides for the TB and 10% of all negative slides. So, they will also check the negative slides as well. Okay. Then the diagnosis of RNTCP. So, I told you there is a sputum analysis, and in the sputum analysis we are using the Zeal-Nelson staining. In the very previous slides I told you. Now, in the RNTCP, we are using the sputum smears, okay, and that sputum smears we will use decolorizer on them or color staining. This is known as Zeal-Nelson staining, okay. 25% sulfuric acid is used as decolorizer, whereas 0.1% Loeffler's methylene blue is used as counter stain, because they have a different nature. The mycobacteria has a different nature, they are acid fast bacilli. So, we are using a different staining here. Yes. Now, see the acid fast bacilli sputum smears for diagnosis of the case of the TB. So, tuberculosis suspect. What are the symptoms? If the patient is showing the productive cough for more than 2 weeks, with or without blood in the sputum, okay, fever for more than 2 weeks, chest pain, weight loss, night sweats, loss of appetite, they will, if the patient is showing all of these symptoms or any of these symptoms, is subjected to 2 sputum analysis, okay. So, we will go for these 2 SS sputum smear examinations. First sample, what are the chances for detection? First sample will show 80%, yes, there are 80% chances, with second sample 93% chances. So, we are preferring for 2 samples, okay, day by day. Okay, so now we will see the interpretation of results of 2 sputum smear examinations. Yes, so there are some conditions like the patient is showing the symptoms, but no sputum test is positive. At that time, what we will do? Give antibiotics for 10 to 14 days, and after this we will see the patient. If cough is relieved, of course the patient is non-tuberculous, okay. But if the cough is persisted, what we will do? We will repeat the 2 sputum smear examination. Another condition is, if one sputum is positive, we will start the anti-tubercular therapy. If 2 sputum is positive, we will also start the ATT, okay. Now, the categories which I have discussed before also, category 1, category 2, category 4th and category 5th patients, yes. Now, see in category 1, the new patients are here, okay, new sputum positive patients or new sputum negative patients, okay, who are seriously ill extrapulmonary, okay. So, for those patients also sputum negative, but they are seriously ill extrapulmonary, for them also we are treating with these anti-tubercular drugs, okay. Category 2 means the relapse cases, the patient is cured and after so many years the infection again revive, and there are some failure cases, there are some defaulters who skipped the drug, okay. So, for those cases we have different therapy. Then category 4th is the MDR TB, multi-drug resistant TB and extensively drug resistant TB. So, there are 2 regimens here, one is the intensive phase or another is the continuous phase. So, in intensive phase it is for the shorter duration, and continuous phase means after that whatever the time period is required. So, we will complete in the continuation. How much duration is here we can see. So, for the new patients duration is 6 months, in intensive phase is for 2 months. We are giving HRZD. So, I am just telling what are these HRZD means. This is isoniazid, yes, H, then rifampicin, Z pyrazinamide and E is the ethambutol, okay. In this continuous phase we are giving the therapy for the 4 months, isoniazid and rifampicin, yes. Then we will see in the category 2. In the category 2 we are giving for 2 months isoniazid, rifampicin, pyrazinamide, ethambutol and streptomycin, and after that for 1 month we will exclude the streptomycin, yes. So, isoniazid, rifampicin, pyrazinamide and ethambutol. After the completion of these 3 months, we are giving the 5 months therapy of isoniazid, rifampicin and ethambutol, which is total for the 8 months, yes. Then for the category 4, we are giving for 4 months kanamycin, levofloxacin, cycloserine, pyrazinamide, ethambutol and ethionamide, yes. Then after that we have levofloxacin, cycloserine, ethambutol, ethionamide for 12 to 18 months, which is accountable up to 18 to 24 months. Last category is the extensively drug resistant TB. In this we are giving high dose isoniazid, H, capital H and small. Yes, then this is capreomycin. Yes, then we are giving clofazimine, levofloxacin, amoxiclav, moxifloxacin and PSD-PAS. Okay, the same you can see here. So the total therapy is for 24 to 38 months. Now this 3 is showing we are alternatively giving it for the in a week. Okay, so 3 times in a week we are giving. Now coming to the daily self administered non-DOTS therapy. As I told you, DOTS therapy, similarly we have non-DOTS therapy. Okay, so where no one is supervising the therapy. So the duration for these type of therapy is more. We can see there are 2 categories in the non-DOTS therapy. First is pulmonary sputum smear positively seriously ill. Second is who are not seriously ill. Okay. So for seriously ill we have prescribed this for 2 months streptomycin, isoniazid and ethambutol, or for 10 months we are giving ethambutol or isoniazid. In the non-DOTS therapy for non-seriously ill patients we are giving HE for 12 months. Okay, so same medication is given for the year, isoniazid and ethambutol. After that, see there is a category 1, 2 and 4th. For these patients it is written that when we will do for the follow up. Okay. So for category 1 we are doing the follow up at 2 months, 4 months and 6 months. Okay. We will see if the sputum smear is showing the positive or negative. Okay. After applying the treatment, means what is the infection level. So this will see. If the sputum is showing the positiveness, okay, at the 2nd month, then after the 1 month we will repeat it. Okay. So here you can see there is a gapping of 2 months if it is showing the negative, okay, the negative test. But if it is showing the positive, we will again do the test at the gap of the 1 month. Okay. So at the 3rd month, and then we will give the gap of the 2 months, then we will see for the 5 months and 7 months. So this you can see here. For the category 2 we are doing the test at 3rd month and 5th month and 8th month. Yes, if the tests are positive, what we will do? We will do the test for 3 months and we will give the gap of 1 month here. So at the 4 month, then 6 month, 2 month gap, after the 1 month, then we will see the 6th month and 9th month. Okay. For the resistance cases, incubation in the intensive phase, we are doing the test 1 in a month, or in a continuous phase we will do 1 test in a 3 months. Okay. Now the drug resistance in the TB. So what is the multi-drug resistant TB? Multi-drug resistance TB means there is a resistance to the isoniazid drug and rifampicin drug. That is why we are prescribing the other drugs in the MDR TB. Okay. Similarly, we have the extensively drug resistance TB, which means the resistance is the microorganism is showing the resistance with the rifampicin and isoniazid. Apart from it, there is a family of quinolone drug. Okay, they are showing the resistance against this category also, and resistance towards the injectable second line drugs. So resistance towards the kanamycin, capreomycin or amikacin. So it requires another drugs as well to prescribe in this. Yes. Then see, XDR TB is the MDR. Okay, means multi-drug resistant TB, but it is showing the other resistance, means resistance to the 3 or 6 classes of the second line drugs. So this is the difference here between the MDR and the XDR. Okay. Now what are the tests which is we are doing in the this TB is the one of the test is a tuberculin test. This is a screening test, tuberculin or Montex test. Okay. So this test is showing the positiveness, okay, positive reaction. If the levels are, you can see the levels here, it will give the 1 tuberculin unit, okay, which is nearly 0.1 ml, okay, of this antigen. So we will give this antigen to the patient, and if it is showing after the 72 hours, we will note the reading. if it is showing reaction more than 10 mm means the positive test, yes, and if it is showing the reaction nearly to 6 to 9 mm, so this area will be inflamed, this area will be in red color, okay. So that will be doubtful. So this is one of the basic screening test which we are doing, Montex or tuberculin test, to identify the patient is suffering from tuberculosis or not, yes.